Thank you for joining us for this targeted oncology virtual tumor board, which is focused on multiple myeloma. In today's targeted oncology virtual tumor board presentation, my colleagues and I will review 4 clinical cases. We will discuss an individualized approach to treatment for each patient, and we will review key trial data that impacts our decisions. I'm Ola Landgren. I'm Professor of Medicine and Chief Attending Physician for the Myeloma Service at Memorial Sloan Kettering Cancer Center in New York City. Joining me today are Dr. Ajay Shah, Associate Professor of Medicine, the Director of Clinical Research in the Multiple Myeloma Program at Mount Sinai, also in New York City. Dr. Alfred Garfall, Assistant Professor of Medicine at University of Pennsylvania in Pennsylvania, and Dr. Nina Shah, Associate Professor at Department of Medicine at University of California, San Francisco. Thank you for joining us. Let's get started with our first case. Nina.
Sure. So the first case involves a newly diagnosed myeloma patient. And so in this case, a 51-year-old man presents with worsening fatigue, dyspnea on exertion, and pallor. And notable in his labs is a hemoglobin of 9.2, which is low. Otherwise, the creatinine and calcium are normal, and the creatinine clearance was normal, LDH also normal, but beta-2 microglobulin was elevated at 4.1, with an albumin also a little bit low at 3.2. Myeloma markers showed an M protein of 1.5 grams per deciliter, and lambda light chains were elevated at 110. Eventually, the patient had a bone marrow biopsy done, and this showed 66% involvement by plasma cells, and on further analysis, FISH showed a deletion of 13q. The patient ultimately had a PET CT, and this showed lytic lesions with an increased SUV, and this was shown in the ribs as well as the femur and bilateral femur and pelvis. The UPEP was done and showed an M spike of 400 milligrams of lambda light chains in 24 hours, and the IFE was positive in the urine for IgG. The patient does have adequate liver and heart function, and because of his fatigue, was deemed to have an ECOG performance status of 1. So overall, the diagnosis is consistent with the multiple myeloma, standard risk, but ISS and revised ISS stage 2 owing to the elevated beta-2 microglobulin and low albumin of 3.2.